and welcome to the second of our Strengthening SOAR Application Series. Today's topic is Medical Summary Reports. What is in that co-signed MSR? Today's webinar is being presented by the SOAR Technical Assistance Center, research associates under contract to the Substance Abuse and Mental Health Service Administration of the U.S. Department of Health and Human Services. My name is Pam Hunt, Senior Project Associate of the SOAR TA Center, and will be moderating today's event. Quick disclaimer, we'd like to remind you that this training is supported by the Substance Abuse and Mental Health Services Administration and the U.S. Department of Health and Human Services. The contents of this presentation do not necessarily reflect the views or policies of SAMHSA or DHHS. They should not be considered substitutes for individualized care and treatment decisions. A few webinar instructions before we begin. You will be muted throughout the webinar. This webinar is being recorded and will be available for download on the SOAR website in about a week. Right now, you may download the PowerPoint slides to view following the webinar. If you look to the top of your screen, you can go to the file icon on the left, see this button, and then hit document to download the materials. You will have a brief evaluation at the conclusion of the webinar, and we ask you to complete it. And we will save all questions until the end of the presentation, and we'll review instructions for asking questions in our Q&A pod. Objectives before we begin. It is our intention that by the end of this webinar, you will learn best practice strategies for strengthening the medical summary report. You'll learn some key strategies for collaborating with medical providers to be supportive of reviewing and signing those MSRs. We also hope that you gain a better understanding through sharing successful MSRs and how strong relationships with your medical providers can lead to positive outcomes for SOAR applicants. So today, so we will be, you'll be listening to two very seasoned SOAR providers, Mariah Morrison, who is a senior social worker at the Equal Justice Initiative in Montgomery, Alabama, and Susie Brady, SOAR specialist and local lead with Integral Care in Austin. They will share with you how they've been able to develop successful collaborations with physicians and really get buy-in for reviewing and co-signing their MSRs. Lastly, we'll hear from Jen Elder, our National Policy and Partnerships Coordinator here at the SOAR TA Center. She'll provide a couple of SSA policy updates, the final rule for medical evidence, and share with you a few of our resources that we've developed for the revised mental health disorder listings. And we'll have plenty of time for some questions and answers. So I am going to hand it over to Mariah Morrison with the Equal Justice Initiative, who will share some of her experiences in Montgomery with writing MSRs and getting support from the medical community. Mariah.
Hi, thank you, Pam. My name is Mariah Morrison. I work at the Equal Justice Initiative. We are a nonprofit human rights organization. The base of our work is on criminal justice reform, and we emphasize addressing excessive sentencing and racial bias, provide legal representation, reentry services, and public education on these issues. I'm going to start by talking about mass incarceration and why I think that's relevant to the MSR. And then I'm going to just talk about my experiences with gathering information for the MSR, collaborating with doctors and psychologists, how I go about writing MSRs, and the importance of creating a record about our clients' lives. So mass incarceration, in brief, means we have too many people in prison for too long. Currently, the United States incarcerates more of its population than any other country in the world. In 40 years, we've gone from having 300,000 citizens in jail or prison to 2.3 million today. Our country consists of just under 5% of the world's population, but we have nearly a quarter of the world's prisoners, being a third of all female prisoners in the world. And incarceration rates for women are particularly troubling. They've increased sevenfold in the last 20 years, and the vast majority of these women are single mothers of children. It's very broad social consequences for these practices. There are reasons instantly that we've reached this point, but one of them is not an increase in crime rates. Incarceration is the result of policy choices. The crime policies, particularly longer and mandatory prison sentences, and the war drugs, with dramatic reductions in social welfare funding, particularly for mental health, have fueled incarceration in recent decades. Men is one of the major contributors to poor health in communities. The millions of people who cycle through our courts, jails, and prisons each year experience chronic health problems, infectious diseases, substance use, and mental illness at much higher rates than the general population. Confinement inside jails and prisons, such as overcrowding, violence, sexual victimization, use of solitary confinement, and lower standards of medical care are harmful to the physical and mental health of incarcerated people. Violent injuries are the most common health problem in jails and prisons. Half of state prisoners and nearly 70% of people in jail have substance use disorders compared to 9% in the general population. Rates of mental illness are between 2 and 4 times higher than among the general population. And preliminary research also shows that there are rates of hypertension, asthma, arthritis, and cancer among correctional populations compared to the general population, even after controlling for a range of socioeconomic factors. Lastly, the number of people in jails and prisons, elderly, have increased more than 5-fold since 1990, and older adults have higher rates of chronic disease and disability and are extremely vulnerable in these settings. And presenting this information is because I think there is an overlap between the populations who are homeless and struggling with mental illness that SOAR programs aim to serve and populations who experience incarceration. And I include the client's incarceration experience in the MSR can be important to documenting functional impairments, both in terms of documenting the trauma exposure from the incarceration experience, the effects of institutionalization on the person's functional ability, particularly if they've been in prison for a very long time. And that's increasingly true. Sentences increasingly longer and longer. There are high rates of trauma among incarcerated populations, and this is both pre-existing trauma from child treatment and then trauma exposure while incarcerated. And you're not already familiar with the ACE study, I strongly recommend taking a look at this. This landmark epidemiological study has been going on for a few decades, looking at the rate of childhood exposure to adversity, and the results of this study have shown that a couple of things, that child adversity is quite common in us, and that the more exposure a person has in childhood, the health outcomes are in adulthood. So they've found a link between health risk and childhood exposure to maltreatment. For incarcerated people, the rates of childhood adverse are quite higher. In some populations, they found it tends to be 4 times higher for incarcerated people than for the general population. So on January 17th, the Social Security Administration began using new diagnostic criteria for mental disorders, and they've added a new listing for trauma and stressor-related disorders. So it's no longer included as an anxiety disorder and has a new set of criteria for identifying trauma-related disorders. Included in the criteria is the experience or witnessing of a traumatic event, which is one reason it's important to be able to document the history, including their incarceration history. And I wanted to share a couple of my experiences in this area of identifying a trauma-related disorder in a client's life. So when a psychologist does testing to assess the level of traumatic symptoms the client is experiencing, the testing often relies on the client's ability to report their experience. And I've said that clients I work with tend to underreport. And because I spend more time with the client and I know them better, I am sometimes able to report either what the client has reported to me or that I've observed to the psychologist to assist them in assessing PTSD in the client. Another thing I've found is that for my clients who have very long and severe histories of trauma, sometimes they don't meet PTSD criteria, even though their functioning seems undermined by their traumatic experiences. So they might not have the classic PTSD symptoms like nightmares or hypervigilance. They might just very emotionally dysregulated. And I've found that these clients tend to get either bipolar disorder diagnoses or borderline personality diagnoses. Sometimes you can assist the psychologist in seeing patterns of difficulty in the client's life, and also describing them in the MSR. If the client is not meeting the PTSD criteria. So since all of the clients I work with have long histories of severe trauma, we always use a trauma-informed approach when doing interviews to gather social and medical history. And I think there's lots of tools there, trauma-informed interviewing tools that you can find online through Google, just the term trauma-informed interviewing. Informed generally means then emphasis on client safety, on giving the client choices, on taking a strengths-based, non-judgmental approach when interviewing the client. I find it helpful to explain the purpose of the interview, and because I am often looking at their functional impairments, on the things that they're having a hard time with, and people can sometimes feel some shame around that, I find it helpful to try to textualize why they're struggling in the way that they're struggling. I think it can be useful also to ask the client if they have ever been incarcerated, but to approach that question with particular sensitivity, again, because the level of shame people experience for incarceration and the degree of secrecy people tend to have around their incarceration experience. I strongly advise not beginning that conversation by asking what their incarceration, what they were charged with, though they may want to tell you anyhow, they may just want you to know. It's particularly relevant to understanding their trauma exposure in prison, and it can be kind of a shaming question. So I don't advise starting with that. And instead, my experience, I found it more helpful in gathering information about their trauma experience in prison to ask about the conditions of confinement. So asking questions about kind of where they were housed, and so, for example, that I asked this question, a response saying he was in a 2-man cell. 5 people. They held 5 people in a 2-man cell, and he was required to sleep under the toilet. And he was the youngest in there. He was 16, and the next youngest person was 30. And so these kinds of details can be very helpful to assessing the experience of the client in this setting. Sometimes you can also just gather information about the facility where they were housed by Googling the facility. Sometimes there will be news articles or there will be lawsuits against the facility, and you can get information about the facility and what the conditions there were like. You also want to note the age and size of the person. The younger and smaller they were, the more threatening and dangerous the environment is for them. Clients have difficulty accurately reporting their functioning for a range of reasons, trauma-related reasons involving avoidance of the memories, or for reasons having to do with intellectual limitations, memory problems, illusions. So it's very important to also be looking to other sources. So finding medical records, finding other professionals who have worked with the client or their family members who can talk to you about the client. The main sources I rely on are the last 3 years of the client's medical records and a current evaluation by a doctor or psychologist. My experience at prison medical records tend to underestimate or misdiagnose client disabilities. So, for example, times I found that clients who have IQs below 70 are going to IQs above 70 in prison records, and that it's been very important to have the client assessed after their release by a psychologist who can do an IQ test to see where IQ actually is. This photo on this slide is actually from a lawsuit against the prisons here in Alabama by the Southern Poverty Law Center, suing the prisons over conditions of medical care and treatment. And this is just an example of kind of the disarray in the medical department. This is a nurse's station in the medical department. These systems are quite overwhelmed. These prisons are very overcrowded. They're understaffed, and the medical staff just can't keep up with the demand. Only 7% of health services in prisons nationwide are accredited, so there tends to be low-quality care received inside prisons. So you have to kind of keep that in mind as you're looking at the medical records. So our clients are first released from prison. I usually try to have a copy of the most recent medical records to take to the doctor, first doctor's appointment with them. And it helps both with continuity of care and with letting the doctor get a fuller picture of the client's medical condition. We haven't had a whole lot of luck getting doctors at the that we go to. We tend to have to go to the federally qualified health clinics for clients to receive care because they don't have a medical coverage. Again, these are another sort of overwhelmed system. The doctors don't have the time to be collaborating with me on MSRs, but they'll find assessments very valuable. Often, again, I will find that the client has more severe medical problems than reported in their medical records. So this identify that usually the clients come out with a range of chronic stress-related conditions, hypertension, digestive disorders, diabetes, that sort of thing. And then I can document in the MSR the client's capacity for managing those conditions. Often they struggle quite a bit to know how to manage something like diabetes through managing diet. So I can document that in the MSR and how that's affecting their functioning. We've had more success collaborating with psychologists. We've had some psychologists who actually have volunteered pro bono services to our agency, and so then I'm able to work with them on assessing the client. It's very helpful to actually have a draft of the MSR ahead of time to present the social and medical history to the psychologist, so that can help them figure out which would be the best kinds of assessments to conduct on the client. And I've also found I've only once had actually a psychologist sign my MSR, and I've more commonly had it happen that the psychologist will actually use sections of my MSR in their report, and so that's one of the ways that I've been able to get my MSR, the contents of my MSR made into medical evidence, is through having it just basically quoted in the report of the psychologist. In organizing the MSR, I try to include information in a strategic way that will lead the DDS examiner to the same conclusion that I'm arriving at, that the applicant has functional limitations that make it so they cannot work at this time. This website is an excellent resource on this. I use the website every time I write an MSR to help on this, and remembering to really humanize the client in that section of the MSR, give a visual image of the client, how they presented in your first meeting with them, and try to tell a compelling story about the applicant's struggles. And one of the most useful tips I've gotten from the SOAR website is to include quotes from the client, include anecdotes, specific anecdotes that illustrate their impairments in a vivid and objective way. And if you're a social worker and you've been trained in writing psychosocial assessments from a strengths-based orientation, you kind of have to remind yourself repeatedly that's not what you're doing here. You're trying to convey to someone that this person is struggling and needs more support. In organizing the MSR, I found it helpful to use the categories suggested on the SOAR website, but I don't use them in the same order or the same categories every time. I change them based on what best fits the client's story, what most emphasizes areas that they are struggling with. And the last section, that's where you connect this history that you've provided to the specific functional impairments that they have. To kind of wrap up, one of the things I love about the MSR is that it's a way to get these untold, invisible silent stories of our clients' lives into the record, and in a way that directly helps connect them to resources that improve their quality of life. And not only provides an income, but it gives clients access to health care, especially is very important in states like Alabama where they didn't expand Medicaid. Clients can become eligible for housing and case management. All of this helps stabilize the client's life, helps keep them out of homelessness and incarceration, can even help them take steps toward employment. Just a list that I wanted to suggest. If you have an interest in understanding the conditions in our criminal justice system, I strongly recommend the book Just Mercy by Brian Stevenson. He's my boss. Trauma Recovery and The Body Keeps the Score are both excellent books about trauma, especially the kinds of trauma that I think people who experience incarceration and experience homelessness struggle with, this lifetime exposure to trauma and adversity. And both of those books are great sources on understanding that. I've included the website for our organization, again, another great resource if you're interested in learning about mass incarceration, the history of racial injustice that has led to mass incarceration. I included the Trauma Center website. This is Bessel van der Kolk Center in Boston, an excellent source on understanding trauma, particularly complex trauma. And then the last built website is a link to the CDC's website, where you can read about the ACE study, which also provides, I think, very good information about the prevalence of trauma in childhood and in particular populations. So that's all of my presentation for today. Thank you much.
Thank you for looking at the value of the MSR through the lens of being trauma-informed, but also a population that we care about very much at SOAR are folks who are justice involved or formerly incarcerated. So I know folks have been taking down lots of notes and getting some great advice about interviewing and utilizing the MSR in a way that's going to help guide treatment and also guide DDS and hopefully making a positive decision. So thanks again for your great presentation. Now I'm going to hand it over to Susie Brady, SOAR caseworker and local lead with Integral Care in Austin, Texas. Susie?
Thank you, Pam. Let's see. There I am. Okay. Hi, my name is Susie, and I'm a full-time SOAR specialist and local lead in Austin, Texas. And I'm going to focus a little bit more on writing, interviewing tips for MSR, and then strategies for provider collaboration. First, I'm going to talk a little bit about my agency. It's Integral Care. We used to be Austin Travis County Integral Care. As I told Pam, we picked the name or the word that was hardest to say in that title and made that the foremost word. But we're the local mental health authority for Travis County. We provide permanent supported housing to approximately 400 people across our community. We do use a housing-first approach and engage people in services, place them in housing, and then offer rehabilitation supports to move them from chronic homelessness to recovery and then housing stability. So I am a full-time SOAR specialist, and I serve one of our programs called the Healthy Community Collaborative. And then we are about to start another full-time SOAR specialist next week, and he will serve participants in our other housing programs. And we also currently have 2 University of Texas School of Social Work graduate students that are doing internships focusing just on the SOAR process. In fact, my intern just got his first application approval this week. And it went by really fast, too. I think it came back from DDS in about 3 weeks. So we're proud of him and that program. So probably the most important point I can make when talking about writing tips and MSRs is don't fear it. I think this is a big reason that caseworkers finish the training and then really never start an application. If you've on the MSR throughout the process, and I know everyone's heard this before, but it isn't as big of a mountain to climb near the end if you work on it throughout. And another way to kind of cut down on the anxiety is to make it your own. Be authentic. We all have our own unique writing style. I think like Mariah was saying, she kind of incorporates everything that's on the template, but make it work within the story for her clients. I'm much more of a touchy-feely kind of sensitive writer, and that definitely comes out more in my MSRs. But if you're more of a technical writer, then be more technical if that's the thing. The most important thing is to get the facts in there, and if you need editing assistance, you can either ask your local lead or your TA liaison to help, and there's always people out there that can proofread. That's an easy thing. But the information and making sure that's in there and making it your own, I think, is what makes it most need. An MSR is what links the DDS examiner to the person behind the medical records. Examiners are just doing their job. Necessarily trained to see the person, they're trained to see the records and then kind of extract the values that they need. The MSR really does paint that picture and provide an excellent summary of the information that the examiner needs to complete the claim. And ultimately, this is what makes SOAR work. The MSR is the encapsulation of what we do. We serve as the connection between the client and SSA DDS, and we make the connections between the client's diagnosis and their ability to work, hopefully as clearly as possible, so it takes as little amount of work as possible on the other end. Remember that you aren't writing fiction here. The information comes from many different sources, and you're just kind of organizing it all into a readable document. Obviously include information from the medical records you've collected, but also use your caseworkers. In some cases, you may be the caseworker, and if so, know if your client is working with other agencies or caseworkers in the area, or if your client worked with other caseworkers in the recent past. I'm a SOAR specialist, and all of my clients have rehabilitation specialists, which are caseworkers, and so I talk to them ahead of time before we get started on anything and ask that they pay special attention to writing descriptive notes that mention functioning, symptoms, quotes from clients, basically anything I could use in the MSR and then send in with the medical records for the application. Our agency also has a Goodwill-supported employment specialist that we contract with, so just be on the lookout if your client has ever used supported employment services. She's worked with most of my SOAR clients, I think, and most clients I feel like are fairly poor historians about their job histories, and if they've been working a lot recently, I tend to request a detailed earnings report from SSA to kind of fill in gaps, and then I ask my supported employment specialist to help. Usually she's helped them create a resume, or they've gone through their job histories too, and so what we do is we'll compare notes. I ask the client again to kind of go back through their history with me, and then I'll use the earnings report as well. And somehow, using all of that together, we can usually come out with a pretty good work history for the report. Also, caseworkers and supported employment specialists and anyone else you know that's been working with your client and has that third-party evidence, they are great to write letters that you can include with the application. And usually I'll contact them about a month before I turn it in, and I have a good idea of what I need them to focus on and what evidence may be missing, like if I need them to focus more on some kind of functioning, maybe concentration, they've been missing appointments a lot, focus. I'll know what I need a little bit more help on for my application at that point. And now for some specific writing tips, I want to start with the importance of quotes. Obviously, you can't make the entire MSR quote, but don't be afraid to use them in your document. They are what make the person real, and they can also be further evidence of symptoms. For instance, I've had quite a few clients with paranoid delusions, gross delusions, that I was able to document in the MSR. For instance, someone watching me, one client worked on a computer trying to find hidden codes on the computer. He believed the government was spying on him. Another client thought she was a lawyer and filing a lawsuit against Amazon for the blueprints for the Kindle. I included a client's letter to the housing authority stating that there were cameras installed outside her apartment, and I sent in photo evidence showing that there weren't any cameras either, and this was all with the client's consent. But it did give a good understanding of kind of what we were dealing with in terms of what the client believed and what she was stating to other people, advocating for herself, and what was really there. Connections for the reader. Don't count on the examiner to make the connection. That's what I always tell myself. Remember that they are only focused on certain things, and making connections isn't necessarily their first priority. Make connections and make them clear in your document. It's a mindset you have to have while writing, and sometimes another thing I do, I just kind of hang notes around my desk with connect or connections written on them just to kind of keep it forefront in my mind the whole time. And it's the template on the website. I believe it is here. And I think I clicked on it, but you should be able to download it or look at it, but I use the actual template part of it at the end, and I have one of those documents for each client. And I send my written notes right the template, and I add the highlights when I'm going through the medical records as well. So then when I sit down to write the MSR at the end, all of my information is already there in that document and organized. I just have to put it all in narrative form. This works really well for me. It may for other people, but it's definitely something that you can try. Also, by keeping template updated throughout the process, it gives me a better understanding of where I need to fill in the gaps and find more information and evidence along the way. Usually that last meeting with the client is me looking over that template, asking questions about anything that I'm unsure about, filling in any gaps. It really helps when it works out that way. Like, it's my best case scenario. I don't always keep it updated perfectly along the way, but when I do, it tends to work out really well. Let's see. Include your firsthand knowledge of the person, your actions and observations from meeting with the client, and I've kind of talked about this a little bit, but those are evidence as well, especially when related to functioning. Your client remember your meetings. Are they able to concentrate? How long can they concentrate? How many times are you prompting them back to the task at hand? Do they remember who you are? How do they interact with other people? All of this can be evidence that you use. And in here to remember to use the new functioning criteria that went into effect January 17th. It's really most of the same information that we're used to getting, just organized a little differently. And all of the templates on the website have been updated. They've been hard at work. Everything is totally updated and ready to go. So you just have to get those there and you're good to go. And with the new functional changes, ADLs are now a source of information, not a criteria. And I like to include problems with specific ADL tasks in the corresponding functional headings to get those for function reports. Anyway, I wanted to go into some interviewing tips as well. And much like Mariah said, possibly the most important word of advice here is the trauma-informed interviewing. Being sensitive to how the process can uncover topics like past and current trauma that need to be approached with both care and sensitivity. Checking in with your client often throughout your meetings, the interviewing process can be overwhelming, and honestly, for you and the client. Secondary trauma, don't forget that you're experiencing everything along the way as well with your client. Don't overdo the sessions. Don't push through to get another portion of the MSR done. If you're feeling that it's time and maybe your client is starting to shut down or start fidgeting when they hadn't been fidgeting, and if you're feeling that you need to end early, then do it. I always like to end each client meeting by revisiting their strengths, sometimes doing some positive affirmation, or just going to something positive that may have happened that week, just something to look forward to. I also like to think in terms of trauma-informed interviewing that I'm asking the person more, tell me their story, like what happened to you, not what's wrong with you, right? On to that, it's important to have an open and honest conversation at intake, just explaining that the SOAR process can be overwhelming at times, and it will involve a lot of revisiting the past and focusing more, I think at times, on just weaknesses, efficiencies, perhaps. I emphasize that the client's disabling conditions don't define them. And although we may be focusing at times on what they can't do and make sure the client can agree that they are much greater and stronger than those barriers they may have. So we talk about strengths the first meeting, and we end every meeting with strengths. And also just making sure that they're aware of crisis hotlines or other agencies or people that they can call if they need support between appointments. This isn't a job interview, is a conversation that I have whenever we complete the function reports together, because we are still required to do this in Texas, even with MSRs. Preface it with explaining that this is not a job interview. Trying to impress me. Don't tell me about your best day and what you do the best. Tell me what it's like to perform these tasks on some of your worst days, the days when your pain is the worst, the days that your depression hits, that you get out of bed, the days that you can't see the motivation to brush your hair. A conversation that we always have to have into the function report, but really throughout. And we're always gathering information. If a client has trouble focusing during conversations, like we've talked about, if they fidget the entire time, if they're making limited eye contact, if they have tangential thoughts, all be used. If your client forgets meetings, if they mix up the dates and the times of meetings, even though that's frustrating, annoying at times, it's all evidence when you look back. And now possibly my most difficult tip to follow myself is simple open-ended questions. I'm quite verbose. I will ask a question and then immediately think of a better way to phrase it. So I add that on at the end and sometimes another phrase, and all that does is add to the noise, and it confuses both you and your client. Ask simple, open-ended questions. Remember, if you ask a yes or no question, you will get a yes or no answer. And if you create and hold a safe space for your client to communicate, then will. New provider collaboration and working with physicians to get those signed MSRs. Now, I believe this is going to be and get a lot easier for us after March 27th when we can use APNs, nurse practitioners, but then, and possibly after, the most important thing to remember here is don't give up. It took me over a year to get dedicated time from a psychiatrist, and that was a psychiatrist within our agency, to see SOAR clients and do evaluations and diagnosis reviews and co-sign my MSRs. And yes, again, this process was just within my agency that I had started advocating for probably more than a year ago. I'm still working on providers in our integrated clinics, and that's been talk with their legal departments. They don't want to be a part of anything having to do with disability, and we're trying to explain that this isn't just the difference between saying that this client is disabled versus an MSR and working with the SOAR caseworker. It took me over a year to get 4 hours a week from a psychiatrist, but it did happen, and it happened with a lot of advocating, information sharing, and assistance from the TA Center. And once you open those lines of communication, don't be afraid to ask for what you need. I detailed emails to the psychiatrist the day before he sees clients just to let him know where this client is in the SOAR process and any pertinent information. I let them know what information may need particular focus on, if it's functioning levels, or just may want to make sure they add to the note if they see it. Let them know if you need any special forms completed for DDS. I would be as transparent as possible. I mean, if they don't see something, they aren't going to write about it, but it doesn't hurt to give them a heads up, and I don't think it ever hurts to ask. To communicate, let them know about cancellations and no-shows, just like you would for anyone. Keep them in the loop. And most importantly, I think keep the physicians up to date on the SOAR approvals that they've participated in. They are a part of your team, and they do care. And so thank them, let them know they are valued often, and can to make it easy on them. They're busy just like all of us. Do what you can, just kind of make things run smoother, and you'll find that the more you do this, the more helpful and accommodating they will be to you as well. I actually had our physician write me the other day just asking how he was doing, if there was anything he could do better, which I kind of looked at as a huge win, because it was us communicating both ways and working together. And probably it was the next day that we got the news about APN. But anyway, that's, I don't know, we'll have questions about that coming up, because I go more in depth on how we did some of those things. But that is the provider collaboration. And that is the end of my part of this presentation as well.
We'll be going to Jen in just a second, Jen Elder, who will be talking about the final rule for medical evidence and the new acceptable medical sources. So we'll be bringing that today too. Susie, thanks again. Just so many great tips through sharing your experiences with, how to communicate with medical doctors and how to share your successes with them. I don't think we do that enough, and I think that's a really effective tip because it is a two-way street, and sounds like you're doing an amazing job. So thanks. I hope you get a lot of questions. So now we are going to throw it over to Jen Elder, National Policy and Partnerships Coordinator here at the SOAR TA Center, who will talk about what Susie was mentioning, the mental health disorder revisions, which have been updated, and also the medical evidence final rule. Jen.
Thanks so much, Pam, and thanks to Susie and Mariah for those amazing tips they were sharing earlier on the webinar. I'm certain everybody was probably writing fiercely and downloading these slides because the tips were so fantastic, and as I was listening, I was like, I wish I had heard these when I first started out as a SOAR case manager. There's just so much goodness in the best practices that you shared, so thank you for doing that. I'm just going to talk briefly on some of the recent Social Security policy updates. Hopefully everybody's had a little bit of a chance to read our news flash that came out last Wednesday, I believe, on the final rule for medical evidence, and something I know we've all been talking about for a really long time. So I'm going to touch on just the highlights, the key points from that rule that I think we should all be aware of in our SOAR work, and then a little bit of a reminder our resources for the mental disorder listing. The final rule that came out last week, now we're talking about it because we put out some information in September about a proposed rule for incorporating advanced practice registered nurses, nurse practitioners as acceptable medical sources. So the wait is over. It was so exciting to see it come out as a final rule last week. So this is something that's actually going to happen, which is very cool. So in the final rule, they did include the APRNs, physician assistants, and audiologists as acceptable medical sources. I think it's actually worth mentioning that physician assistants wasn't in the proposed rules. Security included that because of all the amazing comments they received from community providers, from researchers, from caseworkers about, the importance of adding PAs as acceptable medical sources. So they made that change based on comments they received. So just a short plug for the power of submitting those whenever we can. So the APRN category includes 4 types of medical sources. So there's certified nurse midwife, nurse practitioner, certified registered nurse anesthetist, and clinical nurse specialist. So lots of different titles that are incorporated into the APRN category. So medical evidence from these sources can now be used to establish a medically determinable physical or mental impairment, which, as you all know, is step 2 of the sequential evaluation. So this is really big. I know we've heard from the SOAR community for years and years how difficult it is to get a medical summary report co-signed by a doctor, a psychiatrist, psychologist. We know that the individuals we serve often have very limited opportunities to see psychiatrists on a regular basis, particularly enough for that they receive a current mental status exam and sign off on the summary report. And so how people are being seen by nurse practitioners, they can sign off on those medical summary reports they're writing, and those will help establish that medical impairment that's needed at step 2 and medical evidence. So when it talks about function as well, so what DDS calls that is a medical opinion. So if you're having your medical summary report signed by a nurse practitioner who's been treating and seeing the applicant, when it talks about functioning, that's a medical opinion, and that's really important for the Part B criteria of the listing. So we need them to document the signs and symptoms, but it's also important for them to document the functioning, or have you document the functioning and then sign off on that on MSR. So another thing that changed in this one is, I know that many of you have been hearing about how DDS gives certain weight to certain medical providers, or controlling weight to somebody's treating source. Well, they're getting rid of this rule as part of these changes. So that rule had given controlling weight to someone's current treatment provider if they were an acceptable medical source. The reason they're getting rid of this is individuals we serve, and just the changing manner of medical treatment is, a lot of individuals receive treatment from multiple providers, and many, don't see an acceptable medical source as their main treating provider. And so it just that rule didn't quite match up with how medical treatment is received right now. So, instead of weighing things, they're going to consider all of the records that they receive, as they always have, and they're going to be, most important factors they're going to be looking for are consistency and supportability in the records. So if you're submitting consistent with all the other medical records, medical information from the same treating source, from other treating source, is it supported throughout the records? And a key part of this is recognize and understand that certain conditions, symptoms may exacerbate during periods of time and go into remission for other periods of time, and that's okay. They're not going to consider that as inconsistent. They're going to understand that. They just want consistency through the records that support that diagnosis, that could meet a listing. They're focusing more on the content, the medical opinions, and less on weighing treating relationships against each other. So there's no hierarchy or controlling weight in consideration of evidence from medical sources. I think this is going to be kind of a great change, because I know for some just how evidence was controlled and all the weighing was very confusing, and so that's good to know that's not going to be the case anymore. So some next steps, just a reminder that these new rules are only going to be applied to applications filed on or after March 27th. So they're not in effect right now, and so they only go into effect in, and I guess just about 2 months from today. So a little bit of a waiting period, but it will be well worth it for the SOAR community, I know, and for individuals experiencing homelessness. So in the meantime, go ahead and reach out to APRNs and physician assistants in your community who are already providing treatment to your potential applicants. Bring them into your SOAR efforts if they aren't already. Talk with them about the disability process, your role, how you help applicants in pulling together the evidence and doing those great interviews that Mariah and Susie talked about. They can help by providing evaluations, mental status exams, and co-signing those medical summary reports. So if you're not already involved and on board in your community, this is a great thing to focus on in the next 8 weeks. It's just a reminder about those revised mental disorder listings. Mentioned a couple times, went into effect last week as well. So if you look on the Blue Book online, those were already updated as of the 17th. A webinar here for what this means for SOAR providers, and that listing or that website here. Another web address for linking functional information for the new mental disorder criteria. So we have a lot of great articles in the online course. All of the old information related to the older rules has all been taken down from the website, so there's no confusion. Encourage you to go check out the resources that we have and reach out to us with any questions. We're happy to put and help, and as was mentioned, always taking a look at those new medical summary reports when you're writing to the new functional criteria. I have.
Great, thanks so much, Jen. We do appreciate the work that you've put into updating the mental health disorder listing resources. So Jen shared those with you all. So if you haven't had a chance to listen to the webinar, it is archived, so you can get that off of our website along with some of the other tools that have been updated, and more to come, more guidance to come on the medical evidence rule. Again, we're all very excited here to see the addition of the new medical sources, the acceptable sources, in addition to how medical evidence is looked at, the consistency and supportability. So I think we're all going to absolutely benefit from these changes, and nurse practitioners, as we know, by nature ask a lot of questions, and they really, really understand their patients very well. And I think, as Susie had mentioned, the ability to work as a team, that you are not writing this MSR by yourself, that we're really excited to see how these new partnerships in this way will be developed, and nurse practitioners are seeing their role now in the MSR process. So anyway, thanks again, Jen, and glad both of our presenters are utilizing the listings and are equally excited about the other changes that are coming. So right now we have plenty of time for questions and answers. We're getting the pod open for you, so that you can type in your question into that Q&A panel that's located underneath the participant tab. So we would go ahead and start putting in some questions to Maya, Susie, and Jen as well. We'd like to have some of your questions. So a question for you, Mariah. It has to do with your use of the MSR when it is unsigned, and having the medical doctor be able to actually quote portions of your MSR in their report. Can you talk a little bit about how that relationship came about, where the psychologist was able to look at your MSR and see that was helpful to him or her for guiding the treatment plan and even the diagnosis?
Sure, yeah. So I've kind of had two different kinds of experiences working with a psychologist on getting a client assessed and then getting the the MSR submitted. I did have the psychologist sign MSR. When we're her, she sort of more time effective to basically kind of write the MSR with me. So I wrote the MSR with the social history that I had gathered, the medical history that I had gathered, and then she did her evaluation, and we talked about her evaluation. Emailed me some of the results of the testing, and I just incorporated that into MSR, and then she and I kind of emailed it back and forth. She made edits and changes in certain areas, and she agreed to sign it. With the other MSRs I've done, where the psychologist I've worked with the same one on a few of these, she was more comfortable running the report herself, basically. So I would send her my MSR with social history, medical history, and have conversations with her about the client. She, in an instance, sent me her evaluation of the client. She's saying, I know you're saying you see these PTSD symptoms. He's not showing up on the PTSD scale that I'm using to test the tool I'm using to test him. And she said, can you give me any examples? She asked me to go back and look at the criteria and report if I had observed or he had reported any symptoms in the listing. And I was able to give her specific examples of instances where he had described or I had observed him having experiences in that listing, and then that was able to support her making a PTSD diagnosis. Testing had also shown, I'm a psychologist, obviously, and I'm sure I'm using the wrong language to describe this, but there's some part of the testing she was doing that also indicating that he was underreporting. And so this was sort of consistent with what her testing had shown. So that's been kind of how that relationship has kind of worked. I've found in sort of both instances, it's been sort of conversations back and forth, sharing a draft back and forth, sharing additional information that I've been able to gather, that's the two ways it's worked out for me.
Right. Also, it's the building of that relationship and that trust between the two of you, that she could look at your MSR and attest that this is how the SOAR applicant is experiencing their symptoms by you being able to report the signs, like what you observed. So she is, that just goes to the supportability of, again, what we talked about, what Social Security is looking at, that a doctor values what we say when it comes to the applicant signs, and being able to support that is really great. And again, it sounds like it takes time. Didn't happen overnight, but before with applicant spending much more time than the psychologist. Psychologist is looking at you to do some of the clinical evaluation, right? By sharing what you've observed, and that's really great. And hopefully others can hear about your approach and be able to replicate that with their own treating sources. I think that's really, really helpful. Because again, it's you may be a caseworker talking to a doctor, and you feel maybe you're not on the same page, but really you are, because the doctor does want to get all of the clinical facts, and you're developing a psychological evaluation that again is leading to the most appropriate diagnosis, which is what you realize DDS needs. So thank you so much for sharing that. This is a really great question, and it has to do with DDS and MSRs. We talked about preparing MSR, getting it signed, utilizing it by treatment. But when your MSRs get to DDS, this question is from an individual who's in an area where DDS may not necessarily value them, okay, or they may not be signed, or they're just not looking at them, I guess, as hard as they can be. Talk to us about how your MSRs are valued at your DDS when they get to that level. What kind of feedback do you get from DDS? And that take time to get your MSRs to a point where they're given again a lot of weight right now.
That one?
That one, yeah. I'd like both of you to chime in on that. How does DD MSRs?
I can say for us here in Austin and Texas that that has definitely been a process, and I know for certain that about a year and a half ago, they weren't SARs at all. And so that's not uncommon, I don't think. We do a lot of advocating. We had to do a lot of trying to find someone that we could talk to about it. We ended up finding out what particular unit at DDS got the SOAR claims, finding out who the management was there, finding a person at DDS that could talk to us about the entire process, and it wasn't easy, but it just kind of chipping away at it a little bit at a time. And then also I had all of the caseworkers that were doing SOAR claims at that time. As soon as they had a SOAR, they knew who an examiner was. We made sure that it had gone to the right unit at DDS, and then we called them right away, and we just, in as nice of a way as possible, just kind of explained, made sure that they knew it was a SOAR claim, because that was another issue for a while, and just making sure that they saw the MSR if it was signed, making sure that they knew that it was signed. Sometimes we would send the MSR in at Social Security, and it wouldn't be updated in time to the electronic record, and so we would send it in again to DDS. Sometimes I'd put it in at the back. For a while, I was putting it in at the back of functioning reports, just to explain that this has the same information and more. We do. It's a process, and I think it takes time, but it's all about educating and advocating, and it's worth it, but just keep going. Don't give up. Keep educating, I think, is what has worked for us. And it's frustrating.
You've taken care, you said, even with their agency, to get to a great relationship with your provider. So communication, and it takes time. So don't give up.
No.
Here's a good question. This is for Jen. If we are going to start a disability application with someone who has most of their medical evidence signed by APRNs or PAs, should we wait until March 27th to submit the application? Do you have any for that?
It's a really tough question. I wouldn't wait. Here's why. I guess I would, go ahead and see if you can start the case. Because what might happen? I mean, yes, most of the evidence is not signed by a current acceptable medical source, but I do wonder if somewhere in the records it's signed by their supervising doctor. That can be the case sometimes. It can also be that there's a lot of great evidence in the file, and DDS just needs that one other piece. And so that'd be a time where a consultative exam, while not ideal, in a lot of cases, could be exactly what you need to get the last piece of evidence for that. So the reason I recommend not waiting is because I would rather go that extra step of possibly doing a consultative exam. I mean, hey, there might be something in the records that avoids it altogether, and protecting those couple months of payments. And so, 2 months of extra payments is life-changing for the people that we work with. And so that's why I would go ahead and see what we can do. Go ahead and starting that claim before March 27th when the rules change. So that would be my guidance.
I want to add to that too that I go to consultative exams with clients. I usually take an MSR, and I've had psychologists ask me for it because it helps them with their reports, and I have one with me that I give to them. I don't know if they've always liked it.
Yeah, that's great, Susie. Again, it can add to a much more thorough consultative examination report. So when you have a CE examiner say, can I have some documents to support my evaluation, then that's wonderful. That's really great. And yeah, so I think we all agree that don't waste any time. Get that in, for many reasons. The information in the MSR is very valuable. And chances are that's supported by the medical evidence that's in the record already. So don't wait. March 27th is a long time away, so we don't want to delay. And those records get aged, so you may have to just get a new, status evaluation. So you may get that in. This is a question, and this could be for Jen first, and then the other presenters, because we do hear this quite a bit. Does DDS actually utilize the MSR when it is assigned by a doctor? Yes.
Yeah, I'll start. They absolutely utilize it if it's unsigned. It's very valuable evidence. Even though, most of us writing it are non-medical providers, it's still great evidence. And so it's often filling in gaps that for information that's not in the medical records. And so, very beneficial. I know, a few of us at the TA Center have been many applications over the years, and so weren't always successful in getting them co-signed. But, ultimately we were able to get those cases approved, even though we weren't able to get them co-signed. So information is very valuable. Still write those, still submit it, even if you're not able to get that co-signed.
Great. Did Mariah or Susie, do you have anything to add to that?
I think. Go ahead.
Sorry, no, I was just saying no.
For us, I feel like it depends on the examiner. I feel like some examiners more, even without the signature, and I feel like some don't. It depends on the examiner.
Mariah?
I wish I had. Yeah, we've seen both. I think some just don't.
I'm not really sure. The last few have not been signed, but they've been in the psychologist's report. So.
I think that's a great tip. We don't hear that a lot. At the TA Center, folks using the MSR and having portions of it quoted in the psychological evaluation, or psychiatric evaluation, mental status exam. So I think that just shows you the strength of this document, again, in providing some of those signs and symptoms that the doctor needs to be able to do a full evaluation and a clinical assessment. So I think that's great, a great tip. I hope folks may start doing that too. And we'd love to hear feedback if folks in the field are showing a physician may not assign it for one reason or another, but how are they utilizing that to guide treatment or diagnosis? We'd love to hear that, other stories, how that approach has been successful. This question, this is a question 2. Let's see. Okay, I think we have this about approaching physicians. Okay. This is when the MSR is considered evidence, okay, and I'm assuming that's because it has been signed. Does Beth still request the function report? And I mean, that could go to Jen, that could go to Susie. Like, what is your experience? And it will depend on really the state that you live in and what the preferences are for DDS. But can you talk a little bit about your experience with that? How about Susie? You have that experience yet?
You're talking about it as evidence?
Yeah. Like, we know that some states, even though you're sending it a signed medical summary report, the DDS still wants you to have a function report with it. So I think that depends. Mm-hmm.
It's something we're still working on. Hopefully, sometime in the near future, we won't have to. But right now, we just think both, no matter what. I mean, we've considered it a win to be able to get our MSRs read and considered evidence, but we haven't been able to get through as far as the function report. So honestly, we'll do the function report and send it in with the application usually, unless we're still trying to get more information. But it's something that they told us I think the doctors, they want to see the form, and that's what they want no matter what. So we do it, and I do it in one of the meetings with our clients, and the questions are kind of silly for most of my clients, and so that kind of, it's fun to make fun of some of the questions, and it does get them talking, and that's when I usually have that conversation about in a job interview, don't tell me how you excel at brushing your hair. You know, tell me on your worst days, on your days when you can't find the energy or the motivation to get out of bed, or on your days when the pain is so bad you can't function. Like, what is that like? Do you say you use the bus for transportation? Do you use the bus? How does that affect you after you use the bus? Like, do you always get to where you're going? Do you get confused after you take the bus? Do you spend the rest of the day in bed? Like, just, you have to push a little bit, because just answering those questions, you wouldn't get the information you need. And you can answer the questions and then kind of add more to it in the MSR. And that's honestly why we started putting the MSRs after the function reports, kind of as an addendum, so that to see that we were putting information and more into the MSRs, and to try a little bit more to get that in. So
I think that's a great use of the function report, especially when your DDS is requiring it to be added along with the MSR. Anybody else have some experience with that?
This is, and I'll just add with that, to not be discouraged if they're asking you for the 3373 as well, and definitely don't take it personally that maybe they weren't reading your, consider the information in your MSR. There is a provision in their policy manual that does say they are required to get 3373 for, particularly for individuals experiencing homelessness. And so a lot of cases, I've got a few states I work with that they still require it, even though they love the MSR. But they still, people working at a job, and that's a box they have to check because, that's in their regulations and that's what their bosses are telling them to do. And so that's where, seeing a lot of that. And some DDSs are waiving that and not needing that extra step, and that's fantastic. We'd love for it to all go that way, but just to not be discouraged, because it's really coming from regulations, not anything really you're doing or not doing.
reinforcement that it is, something that DDS really does require. Like Susie said, the medical consultant at DDS requires it. So I think, like Susie said, have fun with it. There's a remark section on the function report, which you can just add, relevant information to make sure it's all captured there, and use it as a weight for your MSR. Sounds like a really great idea.
Another thing about function reports that we've noticed is that some of our examiners have sent third-party function reports, and I usually have our caseworkers fill those out, but we have noticed that those tend to really help is when we do have someone filling out a third-party function report as well. And I share with them what client has written and what I've written, but they write down what they and their observations from working with the client for however long. And it just seems like that's really added to a lot of our claims as well.
Great, bringing up the third-party function questionnaire. You can have that completed by someone who knows the applicant well, whether it's a supported housing worker or even a supported employment specialist. They can answer some of these questions because, again, they spent a lot of time with the individual and have even provided support in completing some of these daily activities. Anybody else have any thoughts on the third party? Utilizing the third-party information with quotes in your MSR, so those folks will be providing that collateral information, and Social Security does put a lot of value on it too. So that third-party information is really critical. We do want to know that those are completed and returned, and include that information in the medical summary report. A good question. They're all good questions. This has to do with, has anyone had success having an MSR co-signed by both a physician, so psychiatrist or psychologist, for the mental health impairment, and other signature for physical health, so maybe a MD, a cardiologist, an internist, regarding clients that have both physical and mental impairments? If so, how did you accomplish this? Have you had experience having it co-signed by doctors?
I had an APN and a MD, but not doctors. Great. I mean,
absolutely.
But there's physical and mental issues.
Right, exactly. And your MSR would show that as well, by the information, the functional information, for individuals with more mental health limitations, and then also physical, having all that information too, and then supported by the evidence. So, great. The more signatures, the better. You can't say no to that, especially backed up by some of the medical evidence. This could be for really anyone who wants to take it. I am new to this process, writing my first MSR. We've all been there. One client reports she doesn't have mental health issues or substance abuse history. I believe her. Will she need a mental evaluation to support this claim? I'm thinking that she doesn't have a mental health diagnosis.
Yeah.
So, take that. It's
the applicants say they don't have conditions, and they do. I guess I'm a little confused about the question.
I think
I don't think so.
I think if somebody's not alleged a mental health impairment, if there's no diagnosis, no symptoms, then we don't need to have it addressed. If there's no substance abuse history, if it's not a problem for the individual, there's nothing in the medical records that indicates, it sounds like you may be trying to prove disability based on a physical impairment then. Remember, you know, Social Security has a definition of disability you need to take a look at. And how severe is that disability? Does it impact their ability to function? Does it impact their ability to sustain work, essentially? So again, the question is no. If a person does talk about depressive symptoms and that nature, yes, maybe DDS would ask for a consultative exam to do a mental status evaluation if there is mention in the record, but it sounds like it's not, so you don't want to address it. So therefore, when you write the MSR, you will not have a psychiatric history section. You will not have a substance use history section. You would leave that out. Like Mariah said, when she does MSRs, she's not using all the headings. She's using the appropriate ones, and she may be moving them around a bit. Okay? So I think we answered your question. This one is fun. It's, again, we're having we have many new providers on the phone. What is the best way to approach providers? I'm brand new at this and would love to know what the best approach is. So this is a good way to end our Q&A. If Susie, in just a couple of sentences, what's the best way to approach the medical community? What works for you?
The thing the most is probably support and buy-in from my boss and my boss's boss. I would advocate with the people, your supervisor and supervisors, and make sure that they support you as well. I think CCing them on emails, I think CCing your TA liaison on emails helps. I think that I just told someone in one of the questions that there's a really good article on the SOAR website about it's specifically for physicians to kind of explain what SOAR is, what the MSR is, and what their help means for it. And I think that at that point you just start off and do it. I think at the beginning I was always a little bit afraid of doctors and somewhat intimidated, but ultimately, I mean, we're here to help our clients and our patients, and all you do is ask and then see what they have to say, and then go there, see what they need and see if you can meet that need. And I've had to get over that fear first. Like everyone's different.
Yeah, and I like what you said, and we'll close with don't give up. And
just
Mariah,
don't give up.
Reiterated that same approach. Just do not give up, and where you can draw on the SOAR TA Center and your local leads and others in your state, just don't give up. And we have that medical provider resource to the website as well. Thanks for sharing with us about that. So I just want to say thanks so much to Mariah, Susie, and Jen. We are out of time, and thank you so much for really creative presentations, sharing such excellent and helpful information. So I just remind you, at the end of the webinar, you'll be asked to complete an evaluation. Please take some time to do that, and join us next Monday at 3 o'clock, January 30th, for our third webinar in the series, and that will be about building your SOAR process with your local Social Security office. So again, until then, thanks a lot and have a good evening. Bye-bye.